all right, all of this then comes down to what do clinicians do about this? There are some clinicians, right, Jeff, who have a zero tolerance policy regarding failed urine tests. What do you think of that?
You know, Peter, it's amazing. I see this in my community all the time, that a patient will come back with one positive drug test, and the clinicians want to, you know, they call me and they want to transfer the patient to me right away because I'm the expert. I have a little background in addiction medicine. And I try to counsel my colleagues that, hey, listen, this is a lab test. It's subject to error. There are false negatives as well as false positives. And that we should never make a clinical decision or base our clinical rationale on one simple test finding, just like in any other area of medicine.
Isn't there also an area of mistrust? I mean, how can you treat a patient if you are telling the patient, I don't believe you, and I'm going to test you all the time, and Lord help you if you fail?
Well, you know, I think, and my colleagues will probably agree, that we've all developed our own styles of telling patients, hey, listen, there's a national prescription drug epidemic problem. We don't think that you're the problem, but we've adopted a universal testing policy. Every patient in this practice is getting tested. We're not selecting you out because we think you're doing anything wrong. And we tell them that it's become part of best practices. And I'd have to say, cost and reimbursement aside, which can be an issue, the patients who are behaving are very willing to give you a urine. It's the patients who are misbehaving that don't want to give their sample.
I would say two things to that too, Jeff, and you're absolutely right. One that I've used is if patients know anyone who are on blood thinners, you know, we regularly test your INR when you're on a blood thinner. You're on a chronic disease management program when you buy into chronic pain medicine. And so I tell them that that's part of it. Because again, it may be a compliance issue. If they have ultra rapid or ultra poor metabolism of certain enzymes in their body, if they may be taking another drug as well and they're not seeing the effect. So there's a lot of different reasons why urine drug testing and other compliance measures should be used that are helpful in practice as well.
So, I'm sorry, go ahead.
Yeah, I would add, Peter, that I think each practice should have their own policy and procedure as to when they're going to start urine drug testing and then uniformly implement it regardless of risk stratification.
Jeff, you do it across the board.
Yeah.
Would you say that you would single out some high-risk patients and not others? Or do you all just do it across the board?
Well, I think like what Chris said, it's when you initiate it. And in our practice, the first time we see you, we do give a urine drug test. And I want to add just a couple elements that have come up, at least nationally, that I know of, where I've been called by friends. You know, what happens if you are practicing in Naples, Florida, but your patient also lives in Colorado and in Breckenridge, Colorado. And in Breckenridge, they're allowed to use marijuana. And now they come down, and within that 30-day period now, they're using it, you know, medicinally or whatever it's allowed for in Breckenridge. And now you do a urine drug test and it comes up positive, and in Florida it's not permissible. What happens then? Right? These are real problems. These are real issues that we're facing nowadays with patients. So urine drug testing is not a end-all, be-all. I think it's part of a compliance monitoring package and has to be used appropriately. In our practice, the first time we engage a patient, we do use it. And we're really using it to screen for other things that they may be on.
Do you guys use contracts with patients? Do you have some sort of arrangement and understanding going in that you sign?
It's routine. And I think one thing about what Joe just mentioned is that whatever risk out there, you're trying to pretty much treat the patient in an informed fashion. You're using a contract, you're using your urine drug testing, and everything checks out okay for many months. But just realize to the primary care doctors out there, the risk out there is constant and dynamic. Everything may be okay for many years, and then there could be an acute decompensation because, you know, son died of cancer over a period of 6 months, and all of a sudden there's chemical coping.
Well, I want
and that's a good point, because you and I published a paper on that, where these patients are vulnerable. And you know, it's miserable to be a chronic pain patient. And so you really have to be the omnibudsman on their side of things. I think what's important to realize is that these type of opioid contracts or informed consents are extremely important too, for the patient to understand risk, benefits, and alternatives. And these contracts should also include some type of quarterly or annual educational process where you can direct them to various websites, or you can direct them to look at their medication guides. And that's how things like REMS and urine drug testing and multimodal, multidisciplinary patterns all come together.
And so we kind of close the loop on this.
I mean, the question becomes, so when do you start contracting and doing urine drug testing? Does it start with tramadol twice a day, or is it 2 Percocets a day? What's everybody's opinion on that cutoff?
And it's not, there's no universal consensus.
Well, you know, we could go on for hours. This is just an amazingly broad
I would say this
topic.
though, Peter, I want to add one other thing.
Sure.
You know, Chris brings up a great point, because what we don't want to do is we do not want to have a decreased access for the patients who do deserve it. And every time that's ever tried to be imposed, like what they did with alcohol in the United States, it doesn't work, right? So we've made a great progress in attempts to address pain. The WHO has said that it's a human right to have your pain properly addressed. Now with new types of abuse deterrent formulations, with REMS, with compliance monitoring, with increased education for providers and patients, I think we're starting to do things in the right path.
All right. What I want to do now